Good day, and now we're busy with the second interpretation of the Partograph. And our objectives here are again that you would be able, after you've done this, be able to interpret the recorded Partograph and recognize any deviations, and to describe the midwifery actions and to decide on a timely referral. And as we've said in the first interpretation, this means basically in your case, referral to a doctor. Now, your assignment in inverted commas was to look at the Partograph that you've been provided with, and instead of a quiz, you were just asked to interpret the Partograph using the 4 Ps, and then also to describe the nursing measures that you would implement, or the midwifery measures that you would implement in the case of this patient on this specific Partograph. So the purpose of my lesson in inverted commas here is to interpret the Partograph for you so that you can check whether your interpretation was correct or not. And please first interpret it yourself before you just listen to my interpretation, so that you make sure that's a good self-test for you before you come to the final interpretation of the final Partograph. Now here is the Partograph in front of you. This is the one that we are going to analyze now. And like in the previous one, I'm going to analyze the specific hours. We're going to analyze it at 3 o'clock, 6 o'clock, etc. So we are going to analyze the specific parts of the Partograph. I'm again going to switch off my the video camera to just make more space on the slides so that you're able to see better. And let's start interpreting. This is just the same Partograph, the maternal part, and here we go now. I'm switching my camera off. Okay, here we go with our interpretation, and what you see in front of you is the Partograph at 3 o'clock when the patient has been admitted. And if we look now here at our 4 Ps, we will see that the fetal heart rate had been recorded here, and it was normal. Again, it was recorded before and after the contractions. Now, I'm not going to say again why it is so very important that we record the fetal heart before and after contractions. I've done that in detail on the first interpretation. So again, still very important. Then if we look at the decelerations and the variability, we see that there's nothing been recorded, or there's just been a stripe saying that they haven't picked up decelerations in this case, and no variability. So it seems as if the fetal heart has not been recorded with the CTG in this case. And the membranes, as you can see here, are intact. Now, if we look at the passenger, we see that the fetal heart's normal. The presentation is a vertex. The position is a ROA. We don't see it here on the Partograph. That's just information that I give you. The membranes are intact. You can see here that it's intact. And the application here we can see is poor. Now, we're not 100% sure. When we come to here, we will see that the head is still very high, and that might be the reason why the application is poor. I haven't said it at the previous interpretation, but the reason why the application is falling under the passage, you can a passenger, you can equally even put it under the passage or the passenger. It doesn't really matter. I usually just put it under the passenger because it has largely to do with the position and also with the presentation, and it's basically how well the fetal head fits on the cervix. So that's why I usually put it here under the passenger. Now, when we look at the passage, we see that in this case, the cervix is 3 centimeters dilated. So this patient is still in the latent phase of labor. The engagement is 5/5 above the pelvic brim. Now we've seen on the big partograph, and here you can also see it, that this is a graph 2 para 1. And in the previous interpretation, we have said that we expect primigravidas, the fetal head, to start engaging from 36 weeks pregnancy and onwards. In the case of multigravidas, the engagement and the descent can take place at any stage of labor. So the patient can come in with a high head, and then engagement might take place through the progress of labor. So we'll have to monitor that. At the moment, engagement of 5/5 means that the head is really quite high. And here we see we also have a descent of -2. So the station is -2. That means that the head is quite far above the ischial spines. There's no molding yet, and we see that there's 200 milliliters. The patient has passed 200 milliliters urine, so we need to make sure about whether there is a full bladder or not as she progresses. We don't know when last she has passed urine, so we must make sure that the bladder is empty. Okay, and in this case also the cervix and the vagina seem to be normal. Now when we go to the next P, which is the powers, as we've said previously, so very important, we see here that there are 2 contractions in 10 minutes with diagonal stripes, which means that the contractions are between 20 to 40 seconds long. Now we got the information here that these contractions are 30 seconds long. So we have 2 contractions in 10 minutes, that's 30 seconds long. Now, like in the previous interpretation, the patient is in the very beginning of the latent phase of labor. So I think it's quite adequate, and if the effectiveness we need to still determine, but I think it's quite adequate for contractions in the early stage of labor to be 2 and 10 minutes and 30 seconds long. We would expect them to become longer and expect them to become more, the frequency which should become more. But at this stage, we are not 100% sure whether they are effective or not. This patient has not been induced. Now, we've said that she was a graph 2. We see that the vital signs are normal, that the urine seems to be normal. There was nothing in the urine, it's only stripes. They haven't started with any medication or IV infusion, which seems from this normal. There's nothing abnormal. We just need to keep the patient well hydrated and to give her lots of glucose-rich fluids to keep her hydrated and to prevent ketoacidosis. And we will talk a little bit more about that just now when we come to the care measures. Pain experienced, we have to find out. According to the contractions, it doesn't look like she's in real pain, but we need to find out and assess and observe whether she can cope with the pain or not. And also the position of the mother is quite important because the head is quite high, so we would like to get that head lower. So in general, if we look at what we see here at 3 o'clock, there's nothing that's really abnormal. There's nothing that really worries us. The passenger is in a good position. The powers we need to still determine. The patient is in a good condition. The only thing that we are worried about a little bit is the fact that the head is so high. So we need to see when the patient progresses, when there's more better contractions, whether this situation will improve or not. So if we look at the care measures during this stage of labor, as we've said in the previous interpretation, we need to assess the patient carefully to make our necessary nursing diagnosis. We have said at this stage that it's sufficient to just give the patient enough fluids and glucose. Small meals at this stage is still okay because she's only in the beginning of the latent phase of labor. There's no real indication to put up a drip in this case. We need the patient to teach the patient to walk around, to take different positions, and this together goes with pain relief. The patient needs education on non-pharmacological pain relief at this stage because the contractions are still far apart and not so strong, in order to enable her to bear with the pain of the contractions. We have said previously with the previous interpretation, and also when we did the Partograph, that there's evidence that that one should not routinely rupture membranes. That does not really speed up labor. It has no good effects, and in this case, with the head being so high, a -2, you have a very good chance to end up with a cord prolapse. The patient needs lots of education regarding nutrition, regarding taking the fluids, regarding her pain relief measures, etc., and also to empty her bladder regularly in order to not cause that the bladder shouldn't cause any obstruction in the head, in the way of the fetal head. Now, when we are on this slide, we are at 6 o'clock on our Partograph, and I've only have the active part of the Partograph, active part of labor of the Partograph here, because at 6 o'clock the patient was 6 centimeters dilated and now in the active phase of labor. So it was recorded here on the latent phase of the Partograph and then transferred to the active part. And as I've explained previously, we make the cross for the cervical dilatation where the cervical dilatation crosses the alert line. So here 6 centimeters fell on the alert line here, and this is where we start our active phase of labor on the Partograph. And now if we look according to our 4 Ps, if we look at the passenger, again the fetal heart still seems to be normal. It has been taken before, recorded before and after contraction. The presentation is still a vertex, the position is still a ROA, the membranes are still intact. Unfortunately, it's not, you can't see, it's not been recorded here, but just on the next recording it was still intact, so one can assume that it's still intact here. They obviously haven't done a good job on properly record the condition of the membranes here. And then we come to, the application is poor, and we don't know what the size of the baby is. So when we look at the passenger in general, everything seems to be quite good for us, except that the application stays poor. And we know that we want good application because the better the head fits on the cervix, we know of the reflex reaction that we get better contractions, we get the stimulation of more prostaglandins, and that stimulates better contractions. So we want a better application. When we look at the passage, we see that the patient is now, as I've said, 6 centimeters dilated. So she obviously has progressed from the latent phase, and she's now in the active phase of labor. Our problem here is the fact that the head is still high. It's still 5/5 above the brim, and it's still -2. The station of the fetal head is still -2. Fortunately, there's still no molding. The patient has passed 150 moles of urine that we don't see here on our Partograph being recorded, but now we must make 100% sure. 2 hours ago she has passed 200 mils, and now she has passed 150 mils, which seems to us kind of normal. So just make 100% sure that the bladder is not full. So when we look at the passage, we feel better in the sense that the patient has progressed a little bit, but the head for some reason still very high. Now when we look at the powers, we see that there are only 2 contractions in 10 minutes. They are between 20 and 40 seconds long, and that might be the big reason for this poor situation here. We can clearly see that these contractions are neither adequate nor effective. They're not adequate because they're not between 3 and 5 contractions in 10 minutes. They might be long enough, but there are too few of them, and they're definitely not effective in the sense that, yes, the cervix has dilated a little bit more, but the head has not engaged, has not gone down at all. They haven't recorded anything about the urine here. There's still no recordings about any medication or IV infusion being given. It looks like from the little information that we have here that the mother is not dehydrated and she's not ketoacidotic. We still need to find out more about her pain experience and what she's doing. Is she walking around? Is she lying in bed all the time? Which might also be one of the reasons why we don't get a proper, a better engagement of the fetal head. So if we look at this picture in general at 6 o'clock, we see that the passenger is normal, except that the application is poor, and that's probably because of this huge, big problem here that the head still sits very high because of probably inadequate powers. We need to look at that. The patient seems to be normal. We just need to find out about her pain experience, etc. Because we also know that pain experience and the way in which she experiences the pain and tension, etc., can have an influence on the contractions as such. When we look at the care measures during this stage of labor here around 8 o'clock, we can almost say the same things that we have said about the labor earlier at 6 o'clock. We still need to assess the patient regularly. We still need to make sure that she eats enough glucose-rich foods, and she can still eat some very small nutritious meals. It's really not necessary at this stage to put up IV fluid for her because she has gone from the latent phase to the active phase just now. There's not any prolonged labor yet, so this is not necessary. This ambulation and freedom of movement is very important for this specific patient because the head is so high. She needs to move around. She needs to change her position. She needs to be in more upright positions to help for gravitation, to help the head to engage. We're not going to rupture the membrane. Still, the head is so high, there's no way that we can rupture membranes at this stage. The contractions are getting longer. There are not many of them. So I would think still, this is still time for non-pharmacological pain relief, and we still need to educate the patient on breathing exercises, upright positions, change of position, etc., in order for the different pain relief, for pain relief. We need to take care of the bladder. We need to make 100% sure that the bladder stays empty. So this is also part of the patient education, to educate the patient to regularly empty her bladder. Now, when we look at this at 8 o'clock, now I have included here on the Partograph both the 6 o'clock and the 8 o'clock so that you can see the progress here. And when we look at the passenger, we still see here at 8 o'clock, this is where 8 o'clock is, that the fetal heart is still normal. There's a little bit of a difference between the before and after the contractions fetal heart rate. We're not 100% sure. That might be a deceleration. So this might be a good place to start with a little bit of a CTG monitoring to make 100% sure that this fetal heart is still okay. They haven't done that. The variability and the decelerations are still not recorded. So this is something that we need to check up. But it looks as if the fetal heart is still normal. Nothing else have really changed here on the passenger side. The presentation is still vertex. It's still a ROA. The membranes are still intact. The application is still poor because we can see here that the engagement is still very poor as well. So according to this, it looks like the passenger seems to be okay. This application still remains a problem. Remember, we've said this is related or linked directly to also the adequacy of the contractions. Now, when we look here at the passage, we see a problem here, because now the patient is 7 centimeters dilated, but she has crossed the alert line. She's falling, this dilatation is falling now here on the right side of the alert line, which tells us that this patient is not dilating 1 centimeter per hour anymore. So here we have a problem, and here is another big part of the problem, the fact that this head still stays quite high. It's now a little bit more engaged. It's 4/5 instead of 5/5, and the descent is now -1 instead of -2, but this is still quite high. There's no molding. There's nothing being recorded about the bladder and more urine that has been passed, so we need to check again on this very carefully. Now, when we come to the powers, we see that there's nothing that really has increased. There's more contractions now in 10 minutes in the sense that at 6 o'clock there were only 2 and now there are 3 contractions in 10 minutes, but they're still only 20 to 40 seconds long. They might be adequate, but on the other hand, for a patient that's 7 centimeters dilated, we expect them to become a little bit more like in 4 in 10 minutes and more kind of above 40 seconds long. So this seems to also be still a weak part in this picture. So the contractions, as I'm saying, it might be adequate, but still it's definitely not effective in the sense that now labor is prolonged and still the head is very high. Now, when we look at the patient, the vital signs are still normal. She has still not received any medication and IV, and we will talk about that just now. She still looks quite hydrated and not ketoacidotic. We still don't know what the pain she is experiencing and whether she still copes with it. The contractions are getting longer and more frequent, so it might be that she starts struggling with the pain relief. So we need to follow up on that very carefully. When one look at the care measures, what do we do now different from what we haven't done at 6 o'clock and 3 o'clock? Now, all these stay the same. Still, the nutrition stays very important. The question arises now whether one should start with IV fluids or not. I would at this stage not start with IV fluids yet. Yes, the labor is a little bit prolonged. She has crossed the alert line, but I think if one keep on giving enough oral hydration, enough fluids and glucose, one can kind of keep prevent dehydration and ketoacidosis. So I would in this case still focus on this. Ambulation and freedom of movement still so important. Change of position, non-pharmacological pain relief still very, very important. At this stage, one can start thinking about pharmacological pain relief. It depends on the patient. It depends on what she prefers. It depends on whether she can cope with her pain, etc. As we've said previously, pain and too much pain might also have an effect on the contraction. So one needs to take that into consideration. And the bladder care, very important. The patient has not passed urine now. Is the bladder not one of the reasons why there's not enough engagement taking place? And then obviously, this very important is now time to refer the patient, to tell the doctor that the patient has crossed the alert line, and that what makes it very important for you to report, obviously it should be part of your guidelines to report a prolonged labor when the patient crosses the alert line. But now the reason when we have done our interpretation according to the 4 Ps, we see here that there are different possible reasons why the labor is prolonged. The head is still high and the contractions are not very adequate and effective. So this might be the time, if the doctor starts doing something, that they can speed up the labor and get it faster. This patient is a graph 2. She's a we don't know, but the first one, we don't see that the first one was a previous cesarean section. So if a previous baby, normal size baby, could have moved through this pelvis, one kind of almost assume that this one can do it as well. Now I'm going to do the 10 o'clock and 11 o'clock interpretation together. Here we see now at 10 o'clock, 10 o'clock is here. We see that this patient they have started now, they've listened to my advice previously to start with the CTG, because we see here a tendency that gradually the fetal heart rate becomes faster and faster. It's still 150 beats per minute, and then it goes up to 160 beats per minute. But when you will remember from the CTG videos that we've done, when you see a tendency that there's a gradual tachycardia developing, it becomes very important, because this might be a very important sign of hypoxia. So this is extremely important. We don't know whether they've only used the CTG here once or whether they used it continuously. I would say this is a definite indication to continuously use the CTG. And we see here now that they picked up when they used the CTG that the variability is fair, and then gradually it increased to poor, and that there are now variable decelerations here. So that's very important. The membrane stayed intact. So if we look now here, I've said here that the fetal heart is normal, but actually the fetal heart rate is still within normal limits. But if we look at the total fetal heart, this is not normal anymore, because we see this tendency. So now we've seen that together with this tachycardia, we're losing variability, which is also a very, very, very important sign. So in general, it's not going very well with the fetus. So another reason why the patient should be reported to a doctor, but also this is becoming time now that this baby should be taken out, because we've said that it can the progress of labor can carry on as long as it can, or want to, if I can call it like that, as long as we have a normal passenger and a normal maternal patient. So here we start getting problems. The application starts being good, so it seems as if the fetal head has gone down a little bit. Now, when we look here, we see that the cervix is now 8 centimeters dilated, and it falls now on the action line. As again, it's definitely 2 hours later. The patient here was 7 centimeters dilated. She should have been 9 centimeters dilated now. So there's definitely prolonged labor. And if we look at the engagement here, we see that the head is still 4/5 above the brim, and the descent is still here a -1, which is very important for us to see. So still the head, in spite of the fact that, or together with the fact that we have prolonged dilatation of the cervix, also the head still sits very high. And now we also here get a plus, 2 pluses molding and 1 plus kaput, which becomes extremely important for us. Now saying that it seems as if this lack of engagement and descent has something to do with CPD. And if we look further, we also see that here at 10 o'clock, there were 3 contractions in 10 minutes. That's longer than 40 seconds. And here we see that there are now 5 contractions or 4 contractions in 10 minutes, longer than 40 seconds. So definitely the contractions seem to be much more adequate now. The contractions are much stronger. So that again tells us that the problem here is not so much the powers anymore, but a problem with the passage and the passenger. and the fact that this molding tells us, almost ensures us that's the problem. Okay, and then when we look at the patient, now we also see that there are ketones busy developing here as well. So the patient's getting ketoacidotic, and this is, together with all the other things, now a certain sign not to give only pethidine and atarax, because at this stage you might really need some pain medication. But this situation should urgently need attention, and I would say this urgently needs a cesarean section, because here at 11 o'clock the patient has now crossed the action line. She's falling on the right side of the action line here. So the position of the mother and all these things are still very important, but the most important is that this pregnancy should now end in a cesarean section. I think I have discussed the most important aspects here regarding the care measures. The one thing that I haven't said that I will definitely do at this stage is, and that's one of the very important things where we know to put up or to start the IV infusion, is when the patient is having prolonged labor, and specifically prolonged labor in this case, and there's also fetal compromise. This patient definitely needs an IV infusion of Ringer's lactate. And that brings us to the end of this interpretation as well. Again, I hope that you've learned. Again, I hope that you have first interpreted yourself before you just listen to the video. And I hope that you will now be able to do your final assessment to be found competent. Go well.